Thank you so much for inviting me. It's a pleasure. When I see those people here, I'm so happy, because if I look back in the past, we had a very close collaboration with people coming from Republic Dominican. Pedro Pablo Diaz and Santiago Valenzuela, they came in Marseille 40 years ago, more than that. And they launched this program of collaboration between the Dominican neurosurgery and the Marseille neurosurgery. And at that time, we had several departments, but all of these departments was very efficient because they came from the same man who was called Professor Payas. And we had many, he was the mentor of all these guys. And you started this program, and then came all the guys. And when I became a medical student, I had one of my colleagues was Jose Cabrera from Puerto Plata, and then I became resident, and he was my co-resident 35 years ago. And I expected that, but yesterday night, I spent the night with Joselito, and we had good time together. He did not change. He was so elegant with the barb, and he didn't change. And we had this very nice discussion with Joselito. It was fantastic, and we promised that we will meet each other each 35 years once. So next time we'll be perhaps in the even. No, I want to shorten this gap. But fortunately, we have young generations here. And Ulysse is here. He went in Timon. Sylvestre, who was my student during years and years. You see here, Dr. Geronimo here came. And the last one was Esther Orgando, who had a very complex education with Moscow and Marseille, and Moscow and Marseille. And so I'm happy for this collaboration, and I'm happy, I hope we will be able to proceed and to welcome a new generation of residents from your country, as you said yesterday night. And I heard that, I understood that. So once again, thank you so much. Today I have two talks. The one is about acoustic, and I see the way you are doing here with radiation for big cases. I guess it's a little bit provocative. You couldn't show that in France, extra large acoustic schwannoma radiated. In France, we have different way to do, but I can understand that there are many, many different ways. And I was surprised by your excellent results. So thank you for that. So my first talk is how do we manage the acoustic in Marseille? I can try with this one. No, this is not the good one. No, please, you mistook. This is not the good presentation. The first one is about acoustic. This one is central skull base, and it will be the second one. If we can change. Sylvestre, can you manage on the dashboard? So acoustic in Marseille, we have a long story because my mentor was Professor Pelé, and Professor Pelé and Professor Canoni. It was a collaboration. This was a story of a collaboration between an ENT surgeon and a neurosurgeon. And they went in the house clinic in Los Angeles at that time. It was early 80s. And they learned about the translab approach, transcochlear, all this fancy, complex approach for the skull base. And they went back to Marseille, and they said, okay, we have to do our own program. And at that time, cases were concentrated, which meant that you had at least four or five centers in France doing the acoustic. Today, there is a huge dilution of the case. Everybody wants to do his own acoustic. And you have 35 centers in France doing acoustic, which means that there is a huge dilution. But at that time, the cases were concentrated, which means that they operated a lot. And they operated everything. Small ones, middle size, large ones, everything was operated. And it changed. I guess it changed. How can I do? Which arrow? This is this one? Or this one, perhaps? I don't have the control. Yeah, this is this one. This picture is from my boss, Professor Pelé. He passed away years ago. But you see the story. If you start at the bottom, on the right bottom here on the picture, you see Dandy and Cushing. They were the first ones to develop this surgery. And at that time, you have to remember 1 century ago that the patient, half of them passed away during the surgery or after the surgery. And if you follow the complex figure, you see that in the 60s, William House, the House Clinic, and all these guys, they developed the surgery, made it more safe and efficient, and then the COS, we are still using the COS classification, intracanalicular, meatal, CPA, and brainstem compressions, COS. Roton, who developed the anatomy of the CPA, the cisternal anatomy with Yazargil, who also showed us the anatomy of the cisterns. All these guys improved our understanding of the schwannomas. And then Majid Sami, of course, in our community is very famous because he popularized the retrosig approach with beautiful results, excellent results. But at that time, during this time, came the radiosurgery with Lexel. And when I started my residency program, we just have the gamma knife in Marseille. It was 1992. And it changed the things significantly. Because, you know, it was early 90s. The surgical techniques were already mastered. The equipment were already down. Monitoring, anesthesiology was excellent. And the functional results were already published. Still some controversy about the classification of the tumor, about the approach, but quality of life of the patient was emerging because, you know, surgeons were happy with the surgery, but they didn't pay attention to the complaints of the patients because of eye dryness, facial nerve deficits, tinnitus, vertigo, all these symptoms. But Professor Pelé, he said, okay, let's analyze the patients which are eligible with gamma and microsurgery. And looking at both sides, he observed that obviously for the patient with CUS2 or CUS3 patients eligible for both treatment, we had an advantage to treat them with the gamma because it was safer and it was a return to work which was shorter than surgery. And Professor Regis and myself later on, we published a lot of these results about the efficiency of the gamma. So then came other studies here. It was not randomized studies, but it was prospective studies, case-controlled studies, cohort studies, who showed the same results. That if you are eligible for both treatment, which means we have not huge tumors, it's probably preferable for the quality of life to go for radiation or fractionation or gamma knife because we are gamma users. So that's why this is our current protocol. For more than 30 years now, we established this protocol in Marseille, which means for intracanalicular, we observe or we treat with the gamma. For COS2 and COS3, we go for the gamma first. And for COS4 tumor, which means that you have a brain shift, we go for microsurgery first. This is our protocol, unless you have special situation like NF2 patient, cystic tumors, trigeminal complaints, then we change our protocol. But most of our protocol is this one, and it's stabilized for more than 30 years now. Of course, Jean-Régis was very active publishing his own results because we treated more than 5,000 acoustic with the gamma, so we have some insights in the analysis, but we also made some meta-analysis with Anne Balossier, who is very efficient with the gamma. And this is the results of meta-analysis of the gamma series in the world. And what we see with the gamma, when the patient is eligible, facial nerve deficit is around 1%, hearing preservation is around 60%, and trigeminal neuropathy is 3%. It was published in neurosurgery 2 years ago. The problem is how does it behave after the gamma? Because from time to time you have failure. It's an argument to say, okay, we won't go for gamma because you have failure. And after the failure, it's more difficult to manage the patient. So in case of failure, you have two two options. First of all, you have to consider that it's not always a failure. It's a pseudo-progression, which means that the tumor will increase, which is very classical, and then move down. And so you have to wait at least 3 to 4 years before telling the patient, okay, this is a true failure. We have to do something. And we have two options. Radiosurgery again, redo radiosurgery or microsurgery, salvage microsurgery. Here, it's flipped, but it was published in Neuro-Oncology, analyzes the pattern of growth after the gamma. It changed, I'm sorry, I don't know what happened. Anyway, it showed us that you have many patterns of behavior after the gamma, and the pattern at the bottom here is the most dangerous, and you have to pay attention to the patients and to follow them carefully. Anyway, in terms of gamma failure, you can redo gamma. If the volume is still eligible, you can redo, and usually it works, and it works nicely, which is counterintuitive because you said, come on, it did not work for the first time, but it worked the second time, but it works in most of the case. And you see here, at the bottom of my figures here, we have new neuropathies in 5% for the 10% for the terminal, 4% for the seventh nerve, and of course, hearing is compromised. But usually it works. So you can redo gamma safely. I don't know if you can redo in case of failure with fractionation. I don't know, perhaps you can redo, but with gamma you can. But there are patients which are not eligible for gamma because it's too big and you have to operate them. And once again, people say, come on, it's going to be very difficult to operate after gamma failure, which is wrong. Because in my own experience, we operate at least 25 of these cases. And it's not more difficult. It's different. You have more adhesion, you have more arachnoiditis when you are doing the surgery. The texture of the tumor can be softened, can be tough. It's different, but it's not more difficult. And once again, you are not obliged to remove 100% of the tumor. You can leave some tumor at the level of the facial nerve and follow the patients. So it's not, the message in my hands, in my experience, it's not more difficult to operate after a failed gamma. So it's not an argument to say, we won't go for the gamma because it's too difficult in case of failure. By the way, failure is only 3%, okay? So we treated more than 5,000 with gamma. I operated only 25. So you see the ratio. What are we doing for large CUS4 acoustic schwannoma? Still, there is some room for radiation, for stereotactic, and you showed nice result with big ones. We are reluctant to go for gamma for CUS4, as I told you, but still, the patient were not eligible for surgery, contraindication because of comorbidity, or patient will refuse the surgery. We can still have some gamma. In this situation here, you see that the patient, it was a big one. We did a gamma, and look at the reduction of the tumor mass in the long term. So it works. It has been published by Jean-Régis and team, and it works nicely. But pay attention that if you treat with gamma, big acoustic, you might expect more CSF problems. And in significant percentage of case, you will have to inform the patient that he will experience some hydrocephalus. Where I don't know where it is written here, but you have between 5 and 10% of patient further shunt. You see further shunt, 5%. Okay, so you have to inform the patient. Probably a risk of more shunt, probably a risk of more failure, but it works and you can preserve the nerves. So if it's small CUS4, you can go for radiosurgery. So, surgery, most of them are eligible for surgery, we know that, but the issue is about the facial nerve and the complications. If you go radical, which is what we did in the past, we removed everything, the risk of facial nerve palsy for radical resection is around 50% of the case, which is nowadays unacceptable for the patient. You cannot tolerate that. If we remove all this benign tumor, you will experience 50% of facial nerve deficit. That's why we change our practice, and gradually we move toward less and less, it is busy, don't worry, less and less radicality of the surgery. Here on the top of the, I don't have a laser, right? No, we do not have the laser. At the top of the figure here, you have radical resection. At the bottom, you have optimal subtotal resection. And for more than 20 years that we did that, we reduce the amount of the resection. We don't go for radical resection for all the patients. So the gross total resection dogma is decreasing of popularity, of course, because of these unacceptable results about the facial nerve. So this is our experience. Yes, I see a lot of acoustic, but I operate only 10% of them because the other ones go for gamma or go for rate and scan. So I only operate large ones. And this is my results about my experience during 20 years. I just operated 350, which is not a lot. We see a lot, but a lot goes for gamma or for rate and scan. And all of them were CUS4. And our philosophy was to remove as much as possible, keeping the fascial nerve safely. And at the time of difficult problem with the fascial nerve during the dissection, I stopped my resection. Well, this is what we did. And you see this kind of tumors we operated, and we classified near total resection. You leave a small remnant, and we obtained that in 60% of case. Subtotal resection, we left between 5 and 10% of the tumor, and we achieved this result in 20%. And subtotal resection, partial resection, you leave more than 10%, and we did that in 10%, which means that radical resection, we still have 10% of our patients who go for a radical resection, total, because the dissection was easy to do, so we proceeded, of course. Okay, what changed? Can you launch this video here? Because I don't have the control. So with this protocol, what did it change? I moved completely from the translab to the retrosig. I was taught to operate with translab. I do not operate any translab anymore. There is still some room from aggressive tumors, for redo surgery, or for invasive tumor, but all of my patients now, I go for retrosig, and which means that it changed the length of the surgery. Surgery at that time was 10 hours. Now it's less than 4 hours. The in-hospital stay is less than 5 days nowadays. And of course, the patient returned to work in more shortly. This is our current protocol. Patient is position, it's not semi-sitting, it's park bench. I remove I withdraw some CSF with small remnant, with small bone flap. This is an internal debulking with your CUSA, which works nicely, by the way. This is monitoring. This is here, the sixth nerve. I try as much as possible to keep the cochlear nerve, but cochlear nerve is very challenging for big acoustic schwannomas. You see that. So this is over there, the trigeminal nerve at the top of the surgery, and we keep the fascial nerve. Okay, this is the way we change our surgery. You see the number of translab in blue and the number of retrosig, the proportion, not the number. And it changed dramatically our way to operate. Because we don't go for radical surgery. The advantage of the translab is you can be radical. Advantage of retrosig is shorter and simple. So this is what we did. So let's move to the next one. So this is here our results. We have 85% of good fascial nerve preservation, which means House and Brackman grade 1 and 2. But still, we have some problem with the intermediary nerve, Risberg nerve. Even so, you keep the fascial nerve, you have to inform the patient that 50% of these patients will experience some eye dryness, taste problems, or disturbance. Fascial nerve is okay, you're happy, but the intermediary nerve is not okay. So you have to inform the patient that this nerve is very difficult to keep. Even so, we kept the fascial nerve. So this is what we do with the remnants. If you leave some remnant, you have two different ways to follow the patients. You can go for radiosurgery first, up front, or you can follow the patient. So we have two different strategies. So we followed our patient with a long-term follow-up here. And this is the tumor remnant we left. You see, 47 patients were eligible for weight and scan, and 53% of our patients were eligible for gamma. Actually, I don't know whether we have to go for gamma or weight and scan for the remnant. And this was the goal of the study, to follow carefully the patient in the long term, to understand if there is a cutoff value of the volume you left with a risk of regrowth if you follow the patient without any gamma. This is what we did here, and you will see how so you have to monitor carefully the patient with I mean recording of the volume with the 3D. It's a volumetric analysis. This is not a planimetric analysis of the remnant, so we have to follow the remnant. Pay attention that the baseline MRI in the post-op shouldn't be too early. If you do the first MRI at 3 months after the surgery, you have some scar, and it's too early. So wait 6 months to 1 year, and then your baseline MRI is at 1 year. And then we follow the patient. You see here, in the green, you have the group of the wait and scan. And in the orange or red, I cannot see exactly the colors, this is the patient who had some upfront gamma after microsurgery. And there is no difference. The p-value is, the log rank show that there is no difference. In both cases, you have an acceptable control, and in the wait and scan, you can see the percentage of regrowth is 21%. But the mean delay for regrowth is 39 months, which means that it's acceptable to leave a remnant and to follow it carefully in the long term. And the problem is, in this case, in both groups, what we left was very tiny. We left with then less than 1 cc. So for less than 1 cc remnant, I can answer that there is no risk to leave a remnant and to carefully follow it without any need to go for radiation upfront after the surgery, which is an important message, I guess. And you see our follow-up, it's around 10 years, so it's reliable. Okay, so the message are, we treat 10%, for large acoustic, large ones, only large ones. The message is, mostly they are eligible for surgery, but still you have some room for gamma, 10% of them. 10% go for translab, particularly in suspicion of malignancy or redo surgery. Mostly we treat them with retrosig approach. 10% retain gross total resection. The other ones go for subtotal or near total resection. We have 10% of 7% fascial nerve deficit, but 50% of the intermediary nerves complain of problems. We are not very good to preserve hearing. By the way, to be honest, in my hands, it's still very challenging to preserve the good hearing in large acoustic. Okay, only 10%. 10% require shunt. 20% will experience some regrowth. We cannot have any predictive factor for this regrowth. And the mean relapse time is around 36 months. So the dogma of radical resection isn't a standard of care anymore because it's a benign some conclusion. So final remarks, there is no kind of value for prediction of the regrowth, okay, even though we treated only small ones. For less than 1 cc remnant, wait and scan is a legitimate strategy instead of doing upfront gamma. The baseline post-op MRI should be at 1 year, not at 3 months because it's too early. And over 1 cc remnant, I cannot answer because our remnants are less than 1 cc. So here are my final remark, I guess, and if I'm available for any question or remark. But thank you for your remark. This is the modern protocol. You're right. But then when I started that, Professor Pellet was reluctant. He did not accept. He said, you have to remove everything. And when I discussed with Taka Fukushima, he always said that you have to remove everything. Why should we irradiate these benign tumors? Okay, we can leave some piece of, and in France, elderly people over 80 years old, they cannot accept anymore the fascial nerve deficit. It's unacceptable. It's a tragedy. So we have to save absolutely our fascial nerve. Save your fascial nerves. Is it finished? I guess yes. Any comment or questions?